Welcome to another deep dive, and today, well, we're diving headfirst into a real brain twister, an ethical quandary that keeps philosophers, like you listening in, up at night.
Absolutely, yeah. We're wading into those murky waters of healthcare rationing, specifically when disability enters the picture.
So get this, we've got a fantastic source, by the way, Disability and Healthcare Rationing, straight out of the Stanford Encyclopedia of Philosophy.
A real heavyweight, yeah. Definitely a cornerstone of bioethics.
So what we're going to do is unpack those core arguments, those persistent ethical knots, those thought experiments.
Yeah.
That, well, frankly, they just surface when you start thinking about who gets what in healthcare, particularly when resources are stretched thin, right?
Yeah, definitely.
So let's get the ball rolling here. Why even think about rationing? Why is this even a thing?
Yeah, well, at the core of it all is scarcity. The plain and simple truth is healthcare resources, you name it. Treatments, medications, equipment, heck, even the time of those dedicated healthcare pros, it's all finite.
It's a finite pie.
It is, right? Like, even think about organ transplants, right? There are just not enough organs for everyone who needs one.
Right.
So if we can't give everyone everything they might benefit from, well, some way of deciding who gets what becomes essential, right?
And that's where rationing comes in, and it's not some villain, right?
Absolutely not.
It's more like a necessary evil.
Yeah, a practical reality.
So one way to tackle this beast, this rationing thing, is to think about efficiency. Squeezing the most health benefit out of those limited resources we got, right?
Yeah, exactly. And that's where cost effectiveness analysis, or CEA for the cool kids, comes in.
CEA, love it.
Right. The whole idea is to compare, what does this treatment cost versus how much does it actually improve health?
But health improvement, that's not just about, living longer, right?
No.
That's where those metrics like QELIs and dailies come in.
Exactly.
Quality-adjusted life years and disability-adjusted life years.
Right, and they try to capture both how long you live and how well you live.
So explain that a bit for our listeners. How do those metrics actually work?
Okay, so picture this, a QAY. It kind of gives a year of life in perfect health, like a perfect score, right?
Yeah.
A 1.
A 1.
But if your health isn't perfect, well, that year gets a score, somewhere between 0 and 1, based on how good or bad, well, the quality of life is in that state. And often, these scores come from surveys, what people think or what experts say.
Right. So it's like a sliding scale of health.
It is, yeah. So imagine a treatment gives you 10 extra years, but your quality of life during those years, it's rated at, let's say, 0.7.
Yeah.
Well, boom, you just got yourself 7 QALIs.
7 QALIs, got it. And what about dailies?
Dailies.
Yeah.
They kind of flip the script, right?
Yeah.
Instead of gains, they look at losses, like how many healthy years you lose either from dying too soon or living with a disability.
So it's like a measure of how much health you're missing out on.
Exactly, yeah. It compares your situation to being totally healthy and says, well, look, you lost this many years because of your condition.
Got it.
Yeah.
So the source brings up this Oregon Medicaid thing from way back in the 90s.
Yeah.
They actually tried to use those QALYs to decide which healthcare services to cover. And, well, let's just say it stirred up a hornet's nest.
It did.
People were not happy.
A lot of controversy there.
It was a bold move, though, to actually put a number on healthcare services and rank them like that.
It was a bold move, and in a way, it kind of makes sense, right?
Yeah.
Get the biggest health bang for your buck.
But even the folks who liked this idea admitted there were some ethical snags, some real head scratchers.
Oh, yeah, for sure. One big one is this thing called the aggregation problem.
The aggregation problem.
Yeah, see, CEA, it loves to add up all the benefits across a whole bunch of people.
Right, so it's looking at the big picture.
It is, but sometimes that means, giving a lot of small benefits to loads of folks might actually trump a huge benefit, even a life-saving one for a smaller group.
So it's like saying, well, we can help 100 people a little bit, or we can save one person's life.
Exactly, and that's what happened in Oregon, remember?
Oh, yeah.
They were all about maximizing those total QALYs, right?
Right.
But it ended up meaning some folks were denied crucial care, care they really needed.
Yeah.
And that's a tough pill to swallow.
Oh, totally. And the source even gives this example of like capping teeth versus treating appendicitis.
Yeah, I remember that.
Because you could do so many teeth cappings for the price of one appendectomy, right? And each capping bumped up those QALYs a bit, so it ended up higher on their priority list.
Yeah, that's the thing with CEA.
Even though appendicitis, well, that can be fatal if you don't treat it.
Right. It highlights this tension between, doing the most good for the most people, that utilitarian view, versus making sure each individual gets a fair shake.
Right. Like, what about their individual rights?
Exactly.
It's not just about the numbers, right?
Not at all.
Okay, so another ethical curveball here is the priority problem.
Right, the priority problem.
CEA, it's obsessed with maxing out those benefits, but it's kind of silent on who should get first dibs.
Yeah, it doesn't give you the pecking order.
So who do we prioritize? The folks who are worst off, those with the most urgent need.
Right.
It gets messy.
It does, and then you bump into this rule of rescue thing.
Rule of rescue, what's that?
It's like this deep down urge we all have to save a life, even if it costs a ton or doesn't give you the most QAYs overall.
Like that instinct to jump in and help, even if it's not the most efficient thing to do?
Exactly, yeah. And then you throw in age into the mix.
Like, yeah, that's a big one.
Yeah, like what about this fair innings argument? Some philosophers think, maybe everyone should have a shot at a normal lifespan, and after that, well, maybe younger folks get priority.
Like you've had your turn, it's someone else's time now.
Right. And then there's the whole can of worms about personal responsibility.
Oh, personal responsibility. Yeah, like if someone makes choices that hurt their health, do they get bumped down the line?
That's the question, isn't it? And it's a tough one. People have different views on this. Some say, absolutely, you got to own your choices.
Right.
But others say, hold on, it's not always that simple. What about genetics?
Right, what about your genes?
Or your environment, where you grew up, your social situation, all that stuff plays a role.
Right. It's not always a level playing field.
No, it's not. So trying to pin down responsibility, well, it gets real complicated real fast.
It's a slippery slope.
It is, for sure.
Now, the source also talks about this democracy problem.
Oh, yeah, the democracy problem.
It's this idea of letting public opinion sway healthcare priorities.
Like letting the people decide.
Right. Like Oregon, remember? They tried to factor in community values with those surveys.
Right. They asked the public, what do you think?
But that raises some philosophical eyebrows, right?
It does, because on one hand, the public's footing the bill for healthcare, so maybe they should have a say.
Right. They're paying for it.
But on the other hand, what if the public isn't all that informed?
Right. What if they don't have all the facts?
What if their opinions are, colored by biases?
Right. Or they just don't get the nitty-gritty of these complex health issues, especially when disability is involved.
Right.
So it's tricky.
It is.
Now, another thing that popped up was this whole idea of indirect benefits.
Indirect benefits, yeah.
Like, should we only think about how much a treatment directly helps the person getting it?
Right.
Or should we also consider the ripple effects? Like the benefits to society as a whole.
Right. Like if someone's healthier, maybe they're more productive, contribute more to the economy.
Right. Or if a caregiver's burden is lessened because the person they're caring for is doing better.
Exactly. Those are indirect benefits. And economists, they love that stuff.
They love a good ripple effect.
They do. They say, hey, look at the bigger picture. It's all connected.
Right.
But from an ethical standpoint, it raises a flag, like, are we just using people as tools to make society better?
Like they're just cogs in the machine.
Kinda, yeah, instead of valuing their health for its own sake.
Right. Their health is important because it's their health.
Yeah.
And there's this idea of separate spheres.
Right, separate spheres.
Like maybe economic good and individual well-being. Well, they're playing on different fields.
Yeah, they might have different roles, different goals.
So mixing them up gets messy.
Definitely. And finally, we've got this clash between fair chances and best outcomes.
Oh, fair chances versus best outcomes.
It's a classic showdown, CEA. It's all about those best outcomes. Maximizing the good for everyone combined.
Right, the biggest bang for the buck.
But then you've got this other idea, this concern for fairness, like everyone should have an equal shot at those resources.
Right, a level playing field.
That's the fair chances camp. And they might even say, well, maybe a lottery is the fairest way to go.
Just draw names out of a hat.
But that feels kind of icky, doesn't it?
It does, especially when those potential benefits are so different, like saving one life versus giving someone a slightly better quality of life.
Yeah, those are tough calls.
So it seems like even before we zero in on disability, this whole healthcare rationing thing is like a philosophical minefield.
It is. It's packed with ethical dilemmas.
But the source says disability throws in a whole other wrench, a unique set of problems. So why is that?
Well, here's the thing. Disability, it's not just like age or gender, right? It's not just another box you tick.
Right.
And it's not just a social disadvantage like being poor. It's intertwined with your health, with your actual healthcare needs.
Right. It's like inherently connected to health.
It is. And while we got to acknowledge those social barriers, those attitudes that make life harder for folks with disabilities, the general idea is that disability often stems from, a health condition, something not working quite right in your body.
So it's like a double whammy. You've got the health condition itself, and then you've got all the social stuff piled on top.
Right.
So having laid out all these ethical landmines in healthcare rationing, let's get specific. Let's talk about why disability adds another layer of complexity to all of this, right? So it's not just another difference. It's connected to health in a way that other things aren't. And the source says that throws a wrench into that whole efficiency argument.
Oh, it totally does, because disability often means you need more health care, right?
Right.
You might have other health conditions going on, or you might need more complicated care that's more expensive.
So some folks might say, well, it's not very efficient to spend a lot of resources on someone with a disability when you could maybe get more bang for your buck with someone else.
Exactly. And that's where those sometimes prejudiced assumptions creep in.
Oh, yeah, like that idea that people with disabilities have a lower quality of life.
Right, even though we have that disability paradox staring us in the face.
The disability paradox, remind us what that is again?
It's this fascinating finding that folks with disabilities, they often report being happier, more satisfied with life than people without disabilities might expect.
Right. It flips the script.
It does. It challenges that whole assumption that disability equals a worse life.
So you might think someone's worse off, but they might actually feel pretty good about their life.
Exactly. And that's a crucial point for philosophers, right?
Totally.
Because even healthcare professionals, if we're walking around thinking disability automatically equals a bad life, well, that can skew those rationing decisions, even if we don't mean to.
It's like unconscious bias creeping in.
Yeah, exactly. And it ties back to that democracy problem we talked about, Societal biases, they can sneak into how we allocate resources.
Right. And on top of all that, disability often comes with extra costs, right? Like assistive technology.
Yeah, assistive technology.
Accessible environments, social support services.
Right. All those things add up.
So if you factor those costs into the equation, well, it could make it seem like healthcare for people with disabilities is less cost effective, even though the actual health outcome might be the same.
Exactly. It's like they're getting penalized for needing extra health because society hasn't quite caught up.
Right. It's not their fault that things aren't fully accessible or that support services are expensive.
Yeah, and that kind of flips that indirect benefits problem on its head, right?
How so?
Well, instead of healthcare being seen as more valuable because of those extra societal benefits, it's seen as less valuable because of those extra costs.
Right. It's like a negative ripple effect.
It is, yeah.
Okay, so now let's get down to brass tacks. Let's look at those head-to-head situations where you have to choose between someone with a disability and someone without, both needing the same limited healthcare resource.
Right. Those real gut-wrenching choices.
Yeah, the source gives some examples to kind of test our moral compass.
They're meant to poke and prod at our intuitions, see what our gut reaction is.
But as the source points out, these scenarios are kind of artificial, right?
Yeah, they're like thought experiments. They simplify things to help us think through the issues.
Right.
But real life decisions are way messier.
Right. Way more nuances.
Way more factors at play.
Okay, so let's dive into one. Imagine this person A has a disability, person B doesn't.
Okay.
Both need a life-saving treatment. It's equally effective for both. But person A is expected to live a shorter time after treatment than person B.
Ah, so they both get saved, but one has a longer life expectancy.
Right. So what do you do?
Well, if you're going strictly by CEA and QALYs, person B is probably going to come out on top.
Because they'll rack up more life years.
Exactly. But ethically speaking, is it really fair to base the decision solely on how long they're predicted to live? Especially if the difference isn't huge and the treatment gives them both an equal shot at survival right now.
Right. You're basically saying person A's life is worth less just because they might not live as long.
Yeah, and that's a slippery slope.
Okay, another one. Both individuals would have the same life expectancy after treatment, but person B is expected to have a higher quality of life because person A has a disability.
Again, those QALYs are probably going to point to person B.
Because of that assumed higher quality of life.
Yeah, but this scenario throws a wrench in the gears, right?
How so?
It forces us to ask, what does quality of life even mean?
Right. Who gets to decide?
Is it something objective, like you can measure it with a ruler?
Like a number on a scale?
Or is it totally subjective, up to each person to decide how good their life is?
Right. What feels good to one person might feel bad to another.
Exactly. And is it even ethical to make these life or death choices based on what we think someone's quality of life is, especially when we're tying it to their disability?
Right. We might be wrong, and we might be letting our own biases color our judgment.
We might be.
And remember the disability paradox.
Oh, yeah, the paradox.
People with disabilities often report a higher quality of life than we'd expect.
Right. They might be more resilient, more adaptable.
So we might be totally off base in assuming that their quality of life is lower.
We might be, and that's the danger of making these assumptions.
Okay, another twist. What if the treatment itself is less likely to work for the person with the disability because of their pre-existing condition?
That one seems a bit more straightforward, right?
Yeah, like if it's less likely to work, maybe it's not worth the resources.
Right. From an efficiency standpoint, it makes sense to give it to someone who's more likely to benefit.
But hold on, the source says even this scenario has a philosophical twist.
Oh, yeah, it does.
What if the treatment might cause a disability in a non-disabled person?
Whoa, okay, now we're talking.
So you've got two non-disabled people. One might become disabled after treatment, the other won't. Who gets the treatment?
Now that throws a wrench into the whole thing.
It does, doesn't it?
Yeah, suddenly those QALYs might not feel so straightforward.
Right, because now you're potentially causing a disability.
You are, and that raises a whole bunch of ethical questions.
Yeah, like, is it better to avoid causing a disability, even if it means someone else might benefit more?
Right, it's a tough call.
And then you've got those health improvement scenarios where it's not about immediate life or death, but more about quality of life.
Right, like improving someone's health, but not necessarily saving their life.
So let's say someone's disability kind of limits how much a treatment can improve their quality of life.
Like they still benefit, but not as much as someone without a disability.
Right. So do you give the treatment to the person who will see a bigger improvement?
That's the question, right? And again, those QALIs are probably going to favor the person without the disability.
But is that fair?
That's the ethical dilemma. Are we penalizing someone because their disability makes it harder to reach that perfect health ideal?
Right. Are we holding them to a different standard?
We might be.
Another scenario. What if the treatment itself is more complex, more expensive for the person with the disability?
Like they need extra care or specialized equipment.
Right. But the final outcome, the health improvement,
Mm-hmm.
would be the same for both people.
So do you go with the cheaper option?
Right. The one that saves resources.
CEA would probably say yes.
But is it fair to deny someone a treatment just because it costs a bit more for them?
Especially if the cost difference isn't huge.
Right. Like, are we saying their health is worth less because it's a bit more expensive to achieve the same outcome?
That's the ethical sticky wicket.
So the source makes this point that our gut reactions in these head-to-head situations, they're all over the place.
They are.
We're not very consistent.
Why not?
And it really depends on the specifics. You know, how big the difference in benefit is, how much extra it costs, even how the whole choice is framed.
Like, are we talking about lives worth living?
Ooh, that's heavy.
It is, right?
Sure.
Or is it a tragic choice between two equally valuable people?
Right. The wording matters.
It does. It can sway our emotions.
So if these individual scenarios are like ethical quicksand, what about looking at disability as a factor in healthcare rationing at a bigger level, you know, like in policy making?
Right. When we're talking about policies, we got to think about fairness across the board,
Yeah.
having rules that apply to everyone equally.
Right. Consistent rules.
And when it comes to divvying up scarce resources, well, some things are just unavoidable.
Like what?
Like the fact that there's not enough to go around.
Right. That scarcity thing.
Yeah, and the fact that some treatments work better than others.
Right. Some are more effective.
And the need to have some way of comparing those health outcomes, which treatment gives the most bang for the buck.
Right. So we need some kind of system.
We do.
And as we've talked about disability, well, it can affect both the cost of healthcare and how much someone can benefit from it.
Right. It's a factor we can't just ignore.
So saying we'll never consider disability in these decisions, well, that seems kind of impractical.
It does. And ironically, it might even be unfair.
To everyone.
To everyone, even people with disabilities.
How so?
Well, imagine you need a treatment that's super effective for most people, but it just doesn't work well for you because of your disability.
Okay.
If we completely ignore disability, you might get that treatment, even though it's not going to help you much.
Right. And meanwhile, someone else who could really benefit from it might miss out.
Exactly. So ignoring disability when it clearly affects how well a treatment works or how much it costs, well, that's not a good use of those limited resources.
Right. It's like throwing good money after bad.
It is, but then we're back to that central ethical dilemma, right?
And where CEA seems to disadvantage people with disabilities.
Yeah, but completely ignoring disability also feels wrong.
So we're stuck between a rock and a hard place.
We are?
So how have philosophers tried to untangle this mess? The source talks about some early attempts, some arguments.
Right. Disability advocates, they've been vocal about this. They've pointed out that this whole idea of lower capacity to benefit, it's often used to mask prejudice against people with disabilities.
Like they're saying their lives are less valuable because of their disability.
Exactly. And they point to times when bioethicists, the folks who think about these things professionally, have actually said that a disabled life is just worth less.
And that's messed up, right?
It is. It's devaluing someone's life based on a characteristic they can't control.
Right, and it's often based on assumptions, not on the actual experiences of people with disabilities.
Exactly, and that's where the debate gets really heated.
So it's not just about being politically correct. It's about challenging those deep-seated biases.
It is, and it's about listening to the voices of people with disabilities, understanding their lived experiences.
Right, because they're the experts on their own lives.
They are.
And remember the disability paradox.
Oh, yeah, the paradox.
People with disabilities often report higher levels of happiness and life satisfaction than we might expect.
Right, they find ways to adapt, to thrive.
So, assuming that their quality of life is lower, well, that's just not backed up by the evidence.
It's not.
But then there's the counter-argument, right?
Yeah, the counter-argument.
Some folks say, well, even if someone feels good about their life, their disability might still mean they can't benefit as much from certain treatments.
Right, like their disability might limit the potential upside.
So it's like, yeah, you're happy, but you could be even healthier if you didn't have this disability.
It's a tricky argument, right? Because it kind of implies that a life with a disability is somehow incomplete.
Right, like it needs to be fixed.
Yeah, and that's where things get philosophically slippery.
So we're back to that question of what makes a life valuable, right?
We are, and the source also points out that those QLI measurements, they can be problematic, because they often focus on the perceived burden of disability.
Right, like how much disability is seen as a negative thing.
Exactly. And that perception, well, it's often shaped by societal attitudes, by discrimination, by a lack of accessibility and opportunities.
Right. So it's like a self-fulfilling prophecy. Society makes life harder for people with disabilities, and then we use that to justify giving them less priority in healthcare.
It's a vicious cycle.
And the source mentions that some philosophers try to defend CEA from a utilitarian perspective.
Right. The whole greatest good for the greatest number idea.
So they're saying, hey, CEA is actually the fairest way to deal with disability because it focuses on maximizing overall benefit.
Yeah, but that argument hinges on the assumption that disability always lowers overall well-being.
Right. And as we've talked about, that's a shaky assumption.
It is.
So if CEA is ethically wobbly, what are the alternatives? The source talks about adding some egalitarian side constraints.
Right, like putting some guardrails on that pure utilitarian approach.
So we're still aiming for the most benefit overall, but we're also making sure things are fair.
Exactly. We're balancing those two goals.
And one idea is to prioritize the quality of opportunity.
Right. The idea that everyone should have a fair shot at a good life, regardless of their disability.
So healthcare is seen as a way to level the playing field.
It is, but even that approach has its limits.
How so?
Well, disability can still affect how much someone can benefit from a treatment, even if they have equal access to it.
Right, so even with a level playing field, the outcomes might not be equal.
Exactly, and that's something even the philosophers who came up with this idea acknowledged.
So it's a tough nut to crack.
It is.
The source also mentions other attempts to find a fairer solution, like prioritarianism.
Prioritarianism, yeah.
Which says we should focus on helping those who are worst off.
Right, give them priority.
But how do you decide who's worst off when it comes to health?
That's the million-dollar question, isn't it?
And what about those indirect benefits?
Right, how do you factor those into the equation?
It's a tangled web.
It is.
And then there's this luck egalitarian approach.
Right, the luck egalitarians.
They say we should only consider disability if the person is responsible for it and it limits their ability to benefit from treatment.
So it's like a double take.
But how on earth do you determine if someone's responsible for their disability?
That's the ethical minefield, isn't it?
It is. It's a judgment call. And those are always tricky.
Always.
Now, the source brings up the UN Convention on the Rights of Persons with Disabilities.
Oh, the UN Convention, yeah.
Does that shed any light on this mess?
Well, it's a big deal because it emphasizes equality, dignity, And it specifically says that people with disabilities should have the same access to health care as everyone else.
The same range, quality, and standard of care.
Exactly. So that's a powerful statement against discrimination.
Right. Like, you can't deny someone health care just because they have a disability.
Absolutely. But the convention doesn't really solve those trickier ethical questions.
Like whether and how we should consider disability when it clearly affects the costs and benefits of treatment.
Right. It's more about making sure everyone gets a fair shake.
So it's like a baseline, a minimum standard.
It is. It's setting the bar for how we should treat people with disabilities.
But it doesn't give us all the answers.
No, it doesn't.
So the source basically says we're still wrestling with this ethical dilemma.
We are. It's a tough one.
And even if we could agree on whether disability should be a factor, we've got this indexing problem.
The indexing problem.
How do you compare different disabilities?
Right. They're so diverse, so complex.
It's like comparing apples and oranges.
It is. And if we say, hey, let's never consider disability, well, that opens up a whole other can of worms.
What kind of worms?
Well, if we can't consider disability, should we consider anything that affects cost or benefit?
Right, like age or lifestyle choices or genetics.
Yeah, and if we say no to all of that, well, the only fair option left might be random allocation.
Like drawing straws.
Exactly, and that just feels wrong, doesn't it?
It does. It feels like giving up.
Kinda, yeah, like we're throwing our hands up in the air and saying we can't figure this out.
So we're left with this impossible situation, right? Ignoring disability seems irresponsible, but considering it raises all these ethical red flags.
Right, it's a real pickle.
So to wrap things up for you, our philosophically minded listener, it's pretty clear that this whole healthcare rationing and disability thing, it's a messy, complicated ethical knot.
It is.
We've explored those tensions between efficiency, fairness, and those special considerations that disability brings to the table. And, well, there are no easy answers.
No easy answers.
This is a debate that's still raging on, both in philosophy and in the real world.
Absolutely. And as you ponder all this, here's a final thought to chew on. If a truly neutral healthcare system, one that doesn't disadvantage anyone, if that's a pipe dream, what should guide our decisions?
Right. What values, what principles?
And how do we make sure those principles are applied fairly in a world where everyone's needs and abilities are so different?
Right. It's about finding that balance, that sweet spot between the needs of the individual and the needs of society.
Exactly. And that, my friend, is the ongoing challenge.
A challenge for philosophers, policymakers, and all of us.